Good afternoon, good morning, or good evening, wherever you are. I am Maurizio Cecconi. I'm the president of the European Society of Intensive Care Medicine. Welcome, everyone, to the second Alive Solidarity webinar. Before I start, let me welcome our many Ukrainian colleagues and friends connected today. I really would like to thank them and praise them for their work in extremely challenging conditions, and also for sharing their experience with us on every day during our exchanges. It is only thanks to them that we are selecting important topics for these first webinars. And today we will talk about hypothermia. Let me tell you, the Society is committed to help over the next weeks and months by bringing to everyone the most up-to-date evidence and learning experience to be ready for the challenges of these uncertain times. We have expert speakers and panelists to answer all your questions. So please make sure that you put your questions in the chat and we will try to answer as many as possible. I will have the pleasure to be also with my friend and President-elect Elie Azoulay, who is joining us later. But now is the time to introduce the first lecture. It's a great honor to introduce a friend and a foremost intensivist, Professor Marco Maggiorini. He's an emeritus professor of the University of Zurich. He was chair at the Medical Intensive Care Unit at the University Hospital in Zurich for 20 years. He's the past president of the Swiss Society of Intensive Care Medicine and an ESICM honorary member. He started his career in research in the field of high-altitude physiology and pathophysiology, with particular attention to the mechanism and treatments of high-altitude pulmonary edema. And the focus of his research was devoted to the pulmonary circulation in the lung. He's author of several papers on hemodynamics, on patients on cardiogenic and septic shock, and in 2001, he implemented and developed the ECMO program in the University Hospital in Zurich. Recent interest focused also on removal of carbon dioxide as a method of protecting lung from mechanical ventilation, and of course, he's also a mountain medicine expert. Marco, it's a pleasure to have you with us, and the floor is yours.
Thank you very much, Maurizio, for your very kind words. It's a big pleasure and honor to be part of this group tonight in this Alive webinar. And also from my side, very warm welcome to all our Ukraine colleagues. The topic that has been assigned to me is to review a little bit the physiology and the clinical assessment of accidental hypothermia in trauma patient as well as in other conditions. So this will be my agenda for the next 20 minutes approximately. I will talk on the physiology of thermoregulation, then to review with you the definition and the classification of accidental hypothermia, then to go a little bit more deep into the problematic of the hypothermia in the trauma patient, then look at the clinics of these special conditions, say a few words about safety of rescuers. I think this is an important topic when we are seeing the situation that are you facing working in Ukraine in this sadly condition. And at the end to review what are the prognostic implications of accidental hypothermia for trauma patients. So when we come to the physiology, just briefly to remind you that we have two closed loops, that in the case of cold, the hypothalamus detect the deviation from the reference temperature and starts inducing shivering and muscle movement in order to produce heat. The heat which is produced and shivering goes back to the brain stem and activates counter-regulatory mechanism if it's needed. If the stimulus is heat, then the reflexes are going through the skin, leading to sweating, to the capillaries covering the skin to open and vasodilate in order to lose heat via the skin of our body. And just to remind you, and this is crucial for trauma situation, but also for toxication and other disease state, that this thermoregulatory mechanism may be affected and impaired by several conditions. Despite these hypothalamic feedback, there are two other mechanisms that are relevant for the control of the body temperature in our body. And one control goes via the brown adipose tissue. In the brown adipose tissue, we have uncoupled protein 1 that creates a leak into the mitochondria that deviate a proton from the ATP synthesis, resulting in a heat production. The quantity of brown fat tissue that we have is a factor that can be increased while you are chronically exposed to hypothermia, and so helps you to keep the core temperature stable around 37 degrees. And the other mechanism that may play a role is, of course, motor activity. We know very well that moving around, we can keep cold, keep warm, and exercise and activates thermogenesis up to 15 to 20 times above the resting metabolic rate. But be careful that too exhaustive exercise may be counterproductive and carries the risk of overextension, leading again back to cooling and loss of temperature. This is a condition that may happen in the mountains while you're exercising, or in a situation where you are fighting in the field. Coming to the definition, the accidental hypothermia is defined as a fall in body temperature and core temperature below 35 degrees. We are distinguished two entities: the primary hypothermic event, which is associated with a outcooling of the body itself in a healthy individual, where the excessive cold is not counterbalanced by the ability of the body itself to control temperature. And then we have secondary hypothermic events that are associated with different conditions, such as trauma in particular, that lead, due to other factors, to loss of temperature. Also medications or illness like as intoxication which impair the autoregulation of the temperature at the level of the brain stem are detrimental, may lead to secondary hypothermia. Exercise, exercise we have seen that plays a role in the development of hypothermia, and mountaineering knows very well, or the mountaineers know very well, what does it mean when they are completely exhausted, sweating, where they lose temperature from their body by convection, then lose temperature by conduction into the field, into the snow or the water on the crevasse, then by radiation and evaporation, you lose temperature. The rate of cooling plays a major role in the prognostic of the hypothermic accident, if you want. And this is nicely shown if you immerse a body into the cold water, and you see in the panel on the right side what is the relationship between the water temperature and the survival time. So as faster as you cool into the cold water, then better is your chance to survive. If this cooling is slow, then the risk of death is very high. Regarding secondary hypothermic event, I would like to briefly mention a few conditions that may be related for the topic of tonight, and in particularly peripheral failure, where you have maybe accident, spinal cord transection, decreased heat production due to exhaustion, and neuropathy may lead to rapid cooling of the body, but also endocrine failure with acidosis, lactic acidosis, due to shock and loss of fluid that may lead also to the production of hypothermic event. and cardiovascular event and other pharmacologic effect due to anesthetics may play a role in these circumstances as well. What I can say about the epidemiology or incidence of hypothermia in trauma patient, if you look at the literature in general, the incidence of post-traumatic hypothermia is quite low and ranges in large populations, retrospective study, between 1 and 9%. However, the post-traumatic hypothermia may be much more detrimental in severely injured patients. And this has been shown in patients with an SIS of 15 and higher. Of course, when we are looking at those epidemiologic data, we have to bear in mind that the different studies that were done in different conditions with patients of different age groups, and this may lead to the differences of the results obtained in these studies. This slide just to remind you that we have 4 common mechanisms that we have to take carefully into consideration while we are transferring the hypothermic patient from the accident place up to the hospital and operating room. And over this period of time, there are several conditions where the environment and the exposure and extraction of the patient lead to a progressive cooling of the body itself. Then, as I said before, the use of medication for sedation and analgesia impairs temperature control of the body, and this leads to more further deterioration of hypotension. And last but not least, we do not have to forget that fluid, crystalloids that are given outside of the hospital in the cold environment and blood product in the OR and emergency room may additionally contribute to worsen the temperature state of the patient itself. At the end, this leads to changes in the consciousness of the patient itself. This slide is just to remind you that consciousness and shivering is something that appears very rapidly as soon as the temperature drops below 35 degrees. And there is a linear relationship between mental situation and the cooling and the body temperature. And this might be helpful, as we'll see later, for the assessment of the severity of hypothermia. The impact of hypothermia on the circulation and on the heart itself, increasing the vulnerability to arrhythmia of the heart, plays also an important role. And as soon as the temperature may drop below 31 degrees, cardiac arrest may be a condition that comes in to play very soon. If not, cardiac arrest may bradycardiac event lowers cardiac output in this condition and may lead to severe death and multi-organ failure. So hypothermia is the trigger for multi-organ failure, and this is what at the end makes the high mortality rate that patients with hypothermia are confronted with. We have seen the fact that the shivering is caused by the hypothalamus stimulus to counteract hypothermia. This leads to acidosis due to high metabolic demand and production of lactate. Then at the level of the heart, I said you have vulnerability due to arrhythmias that may lead to even ventricular fibrillation and cardiac arrest. At the level of the coagulation, red blood cells, this is very important other mechanism that may lead to multi-organ failure in such condition by platelet dysfunction and coagulation activation, so-called the coagulopathy of the traumatic patient. if hypothermia came into play, acidosis and coagulopathy are the deadly triads for the patient this has affected. Hypothermia, however, has also an impact on renal function, where we have a cold diuresis and further fluid loss, and we have impact on the lung as well as on the gastrointestinal system. So it's a multi-organ dysfunction like sepsis and other severe conditions that are caused by severe hypothermia, in particular with traumatic context. Let's come to the clinical aspect. As I said before, we can use the clinical symptoms that are found in the patient injured in the field to classify the deepness of the stage and deepness of hypothermia. If your patient is shivering, you know that the temperature should be above 30 degrees. Below 32 degrees up to 28, shivering is lost, and which further causes a decrease in temperature itself. And below 28 degrees, the patient is mostly unconscious, but with still persistent vital signs. And after 24 degrees, you have a condition that it's called an apparent death, where the patient has no vital signs detectable and is in apnea. In these differentiation between the stages may be confused, may interact with the conditions in the field. So the traumatic patient, where there are other causes that may lead to impairment of vital sign or impairment of consciousness, play an important confusing impact on the assessment of the hypothermic patient in the field. So that at the end, what it's needed is the measurements of the core temperature to really assess the condition of the patient. And nowadays, the measurement of core temperature should be done at any time outside of the hospital. In this condition, thermistor-based epitympanic probes are suggested to be used in non-intubated patients. Deep nasopharyngeal measurements could be an alternative to the tympanic thermistor in a patient with impaired consciousness while are lying in the field, and esophageal probe measurements is strongly recommended in patients who are intubated. In the hospital, there are other measures that are frequently used, and most frequently is urinary bladder temperature, the method that you can find. We have to pay attention that infrared epitympanic devices are not fiable enough to assess body temperature and may just be used to screen the temperature. And other measurements such as rectal temperature measurements or bladder temperature in the field are not appropriate, because you expose your patient to further cooling due to the method, to the access way for this thing. One point that you need to consider, and it's an important point that may lead to the death of your patient, is the afterdrop. And what is the afterdrop is a fluid cooling that moves from the periphery to the core part of the port, leading to sudden cardiac death and circulatory collapse. And this is a point, something that you have to avoid. And classically, this happens while you are starting to warm up your patient in the field and the skin starts to dilate and brings this cold blood into the core of your body. And just to show how this could be lethal, this is a case report that has been published a few years ago, where a patient who was buried by an avalanche was wearing a watch, and this watch was recording his heart rate. You see here on the left side the temperature and the heart rate and the elevation of the patient. So the patient was buried at an elevation around 2,500 meters while he was ski touring. You see this is the burial time, and you see how his heart rate was changing initially and then stabilized over more than close to 2 hours at the level of 108. And where close to the end of the burial period, when the patient was extracted, suddenly the heart rates dropped to 0, and the patient, when he was extracted, was dead. So we have really to pay attention how we move the patient in the field in order to avoid this deleterious afterdrop or cardiac arrest situation. Safety is an issue in the field, not only in your condition, but also in the mountains, other avalanches, other water or whatever can come into the place where your patient is lying. So first of all, you have to watch whether the rescuer can be safely at the place of the patient, or you have to move the patient to another place where it is most safe for the rescuers. And one of the important things that the rescuer has to assess initially is there are obvious signs that your patient is deadly injured. And so then you don't have to expose yourself when there is no hope to help this patient surviving. And then you have to try to assess once you are close to the patient whether he's in cardiac arrest, and start with resuscitation if indicated from the condition, and if you have the resources to do it for a long period of time. And if the patient has vital signs, but that is not completely arrested, rescuers should avoid causing cardiovascular collapse, just what I have said. So handle gently your patient when you are moving around and rescuing him at the end. Okay. So to the end, what are the prognostic implications of this accidental hypothermic condition? Accidental hypothermia may be associated to increased mortality. The literature is not clear at the end whether hypothermia by itself is the cause of mortality, or it is the multi-organ failure and the triads of acidosis, coagulopathy, and hypothermia that at the end lead to the death of the patient. Then hypothermia is a risk factor also after the patient has been carried to the hospital. We know that those patients are more prone for surgical site infection during trauma laparotomies. And at the end, we do not have to forget to minimize, as I said before, further loss of the temperature while we are rescuing the patient into the safe condition of a hospital. Thank you very much for your attention, and I'm glad to answer your question if you need.
The next lecture, so it's a pleasure to welcome on stage Dr. Peter Paal. Peter is a consultant, the head of anesthesiology and intensive care medicine at the Department of St. John of God Hospital in Salzburg in Austria, and he was a member also of the COVID-19 Crisis Committee. Since 2018, he is the research lead for the International Commission for Mountain Emergency Medicine. He is a board member of the Austrian Society of Anesthesiology, Intensive Care and Resuscitation, member of the Education and Examination Committee of the Austrian Society of Anesthesiology, Intensive Care and Resuscitation, and vice president of the International Mountain Medicine Society. He has authored more than 190 papers, several books, chapters. He's a reviewer for 30 journals, and one of his main fields of research is indeed accidental hypothermia. So we look forward to hearing from him how to do the assessment and initial treatment of these patients.
Thank you very much, Maurizio, for the kind invitation, and it's a pleasure to be here with you. So I'll just go to share my screen, and after the excellent first lecture of Professor Maggiorini, I will just continue directly with the treatment strategies in difficult situations. I thought that it's not only, well, actually, I do not have any conflict of interest. And in these difficult times, it's not only accidental hypothermia, which our Ukrainian colleagues and colleagues also in other remote areas will encounter, but it's also about local hypothermia with non-freezing cold injuries. You may have heard about the trench foot as it appeared in the First World War on the Flanders and French frontiers. And also the freezing cold injuries, which is called the frostbite. And there's also, of course, the accidental hypothermia when the whole body is, of course, influenced by hypothermia. So first, I would like to talk about local hypothermia. So the non-freezing cold injury is certainly something which soldiers at the front will encounter if they're digging trenches and they're staying in an ambient temperature above 0 degrees. So the environment may be wet in these trenches and they will stay there for hours or several days. The boots are tight, and importantly, there's a dysfunction of the microvasculature, and there's also some peripheral nerve injury, which may lead to ataxia and finally also to neuropathy and to final tissue necrosis. This is how it looks like. So you see this wet, cold feet, and they may not be able to walk for days, weeks, or months, or even for the whole life. On the contrary, frostbites, like with the freezing cold injury, is normally encountered with a temperature below 0 degrees, but that may also be different if it is wet and windy. So especially with strong winds, like in the plains in Eastern Europe, also temperatures above 0 degrees may turn to a felt cold below 0 degrees on the skin and cause also frostbites. And normally frostbites, in contrary to non-freezing cold injuries, develop already within a few hours, not only days, and there are peripheral arterial microthrombi. So this is very important, this difference, because this then will lead to a different therapy, of course. So how should we prevent these local hypothermia injuries? So actually, cold should be, of course, avoided, or if it cannot be avoided, at least there should be some protection. Importantly, the perfusion should not be limited, so it's important not to wear new and too tight boots, as it is used in war times, for instance, or new clothing which is too narrow. Then people should be well nourished and also hydrated. And it's important to rotate the personnel between in the cold and out of the cold. And if soldiers are outside, they should basically at least, let's say, be around in pairs, just to make sure that the boots are removed occasionally and the socks are still dry. So this is very important. The treatment, if a non-freezing cold injury has occurred, is a warm environment. It's important to remove the clothing as soon, if it is wet, as soon as the patient is in the warm environment, and there should be some gradual rewarming. And you should consider in this case, because there may be some tissue injury as discussed, some tetanus booster, analgesia that may be systemic, also regional, and there may also be some treatment required for neuropathy later on. With the frostbite treatment, it's different because, as we have heard, there are some arterial microthrombi in the affected limbs. That means we require to reduce the duration of this tissue ischemia. We require a rapid rewarming in a warm water bath, only in the warm environment. This may be painful, so we may consider more strongly even than with the non-freezing cold injuries, systemic but also regional anesthesia. That's certainly a good option. And then for 8 days, the treatment, as far which is the best, should be with aspirin and prostacyclin. And for special cases, but only on the first day, you should consider also some local fibrinolysis. If you do not have prostacyclin, heparin may also be a good option. So now let's come to the general hypothermia affecting the whole body. We have heard already this is called accidental hypothermia. Importantly, as soon as the body cools, oxygen requirements are less. So this is why if people cool down, they need less oxygen, which may be a good thing. But of course, as we have heard, if the body temperature approaches 32 degrees in elderly and old and sick people and 30 degrees in young and healthy, the myocardium may go into cardiac arrest, which is a bad thing. People can survive a hypothermic cardiac arrest for a long time. So resuscitation for a long time may be possible in a no-flow blood state and a low-flow blood state during CPR until the body is rewarmed so that the myocardium may start again with beating. But importantly, such a hypothermic cardiac arrest can only be survived if hypothermia has ensued before hypoxia. And in most cases, at least with avalanches, but certainly not in Eastern Europe, often there is hypoxia first and only then thereafter hypothermia. So consider this situation. So hypothermic patients may survive cardiac arrest long if hypothermia ensues first and hypoxia only secondly. We have seen this already before. This is very important for the treatment, also the staging of hypothermia. If you are in a difficult situation and you do not have a core temperature measurement, just look on the vital signs. So the vital signs may give you an indication of the core temperature in which the patient may be. Shivering is a very poor predictor, and there has been a new revised Swiss staging done, so new staging done of this Swiss hypothermia staging, which is this one which I present to you, which may be a good option for difficult situations as you may find right now. So the recommendation is for this revised staging that you basically only look on the consciousness level. And as long as the patient is fully alert, the risk of cardiac arrest will be low because he will not be very cold. As soon as the patient becomes confused and obtunded, the risk of cardiac arrest becomes already a bit higher. So risk of cardiac arrest due to hypothermia. If the patient becomes only responsive to verbal actions or only to painful stimuli, the risk of cardiac arrest increases. And if the patient is unconscious, then the risk of cardiac arrest is very, very high, or he may already be in cardiac arrest. I will not go into detail of therapy right now, but just to be reminded, let's just relate consciousness level to the risk of cardiac arrest in hypothermic patients. How do you assess hypothermic patients if you do not have a thermometer? Just touch them on the trunk where they are protected by clothes. And then you may feel the cold body, and that may indicate that the patient is not only cold on the fingers, but also on the chest and on the abdomen. We have heard already about the deadly triad in trauma. So hypothermia does impair coagulopathy, increases acidosis because there's less oxygen carrier. And this again deteriorates thermoregulation centrally and peripherally. Does this make a difference? Yes, it does. This is, in my opinion, or in our opinion, probably the best indication that even mild hypothermia may lead to a substantial increase in bleeding. So this is a meta-analysis of colorectal surgery patients, and the only issue which basically divided the two groups was a cooling on the core temperature of 1 degree Celsius, and this already increased the intraoperative risk of bleeding and the risk of transfusions of packed red blood cells. So, and this is just 1 degree Celsius in elective colorectal surgery patients. If you look at the admission temperature in hypothermic trauma patients, then you see an exponential increase in the rate of mortality between a normothermic patient admitted to the trauma department, and this is data from North America, from a large trauma registry, and the risk increases exponentially for death with a core temperature falling to 32 degrees and even lower. So the conclusion here is to avoid hypothermia, because as we have seen, it impairs coagulation, but it also is related to mortality. New studies have also further underlined these findings. If we look at findings in thromboelastometry at different levels of hypothermia, as we have discussed, then we see a definitive impairment in the coagulation testing. And this is blood of normothermic patients, which has just been cooled in vitro to the different levels of hypothermia, which we have seen in the staging. And this is, for instance, again, the platelet function just investigated with a multiplate device. And you see with very low temperatures, there is almost zero or very, very little rest function in these platelets. And if you look at the confocal microscopy here at normothermia with a nice fibrinogen or fibrin network in normothermic patients, and you cool down the blood to lower temperatures, as you see here, and very low temperatures, the fibrin network completely disappears. So in summary, platelet function, but also fibrin building capacity of the plasma coagulation factors are severely inhibited by hypothermia, and we know clinically that already 1 degree Celsius makes already a difference. We have seen this before. I just want to remind you that whenever you do treatment on patients who may be normothermic at the beginning, on scene when they have been shot or when they have been involved in any accident, with everything we do, being it analgesia, anesthesia, or infusions, we certainly diminish core temperature, and as we know, this is deleterious. So, in summary, again here, we should limit our pre-hospital treatment as much as possible if transport times are short, let's say shorter than 1 hour, and do as much as possible in the hospital. The International Commission for Mountain Emergency Medicine, ICAM-MEDCOM, has developed a multiple trauma algorithm published just 2 years ago. And this is basically for mountain, but also for remote areas. And I just want to raise the awareness on how to treat these patients. So this is a huge algorithm. We cannot go into detail, but from the top to the bottom, basically, we see that after the initial assessment and the primary survey with the ABCDEs, we go down further down to a more profound primary survey, and there, most importantly, hypothermia should be prevented. And this is important for the pre-hospital setting with insulation and maybe heat packs. We come to that later on. And of course, as you see further down in the algorithm, there should be a definite treatment then in the trauma center or in the next hospital where you can go to, depending if there is, with different treatments options, depending if there is a traumatic brain injury or if there is an uncontrolled hemorrhage. So this will lead to different therapy options. And also the European Society of Anesthesiology and Intensive Care a few years ago has stated, let's say, given recommendations on the perioperative bleeding assessment and management. And I just want again to raise your awareness that normal diagnostic coagulation tests like the PT and PTT, they are typically performed at 37 degrees. So even if you have a hypothermic patient with, let's say, 35 or 32 or even less degrees Celsius, you take this cold blood sample out of this cold patient, you put it into the machine, and this machine will just, for standard reasons, rewarm the blood to 37 degrees, and then you will just get normal coagulation values for 37 degrees. So the recommendation here, also from the ESICM and this working group, was to maintain perioperative normothermia, and this is certainly also true for trauma. This is just the massive transfusion protocol from our hospital. It's in German, but you will find different ones also on the internet. But again, just want to raise the awareness that the core temperature based on the modern data we have today, is to keep a core temperature of 37 degrees, besides the other parameters which are required in bleeding patients. So what should you do pre-hospitally with a hypothermic patient, or who is wounded and he may be at risk of hypothermia? Basically, you should try to diminish bleeding in such patients, and therefore splinting of bone fractures and immobilization, as you see here in the background with this gentleman, is already decreasing bleeding, and therefore slowing the deadly triad of hypothermia, acidosis, and coagulopathy. And of course, you should try to insulate the patient from the cold, from the wind, and from the wet environment. Importantly, you should also cover the head when you transport the patient, because in a fully suited patient, like here with this apparel, 1/3 of the rest heat loss is just above from the head. So just cover the head with some equipment. Then there is the question: should we use large chemical heat beds? And interestingly, at least in experimental studies, there was no faster rewarming with large chemical heat beds, but patients feel more comfortable. And then there was the question: should we basically remove the wet clothes as compared in a cold environment as compared to not remove them? And basically, you can just leave the wet clothes on, but importantly, you have to waterproof cover and insulate the patient from water evaporating from his surface, because that will further decrease the core temperature of this patient. So just leave the wet clothes on if there's not option, cover him well, and just wrap him waterproof, as you see here in the background. So what about analgesia in these terrible times, and anesthesia? What should we do? We know that anesthesia and analgesia inhibit the central but also the peripheral thermoregulation, and so both are bad and will certainly decrease the temperature by 1 or 2 degrees from on-scene to hospital admission. In cold times, probably even more. And this is just a eminence-based statement that probably ketamine, because it's a fast and good acting analgetic, and it has some vasopressor or catecholinergic agonistic effects, may minimize cooling as much as possible of all analgesics. And this is also a very interesting topic. So the practice guidelines of our colleagues in Canada and British Columbia, you may know what this is. So this is a classical burrito, and basically this wrap keeps the burrito warm. And so our colleagues in Canada called this the hypothermia burrito. And again, just similar to what I've showed before, you can use chemical heat bags, you use some mattress, you can also use some rescue foil, and you protect the patient outside against wind and moist environment, and you just protect also his head with a cap. And this is then excellent hypothermia burrito, and for transport, this whole setting will reduce cooling. So how do you rewarm these patients? So basically, as long as the patient has still some circulation, you do not need a cardiac support. And I think for different environments, this is the best option. So you need a warm environment, you need clothing, you need warm, sweet drinks. And if the patient is still able, you may actively move him, and this will rewarm the patient with a rate of 2 degrees per hour. If the patient is not shivering and not able to walk, then you may actively externally rewarm him with some heating air, for instance, or warming mattresses in the hospital, also with some warm infusions. And then there are different other options, but they are more of historical, anecdotal interest. And finally, if the patient has arrested, then the extracorporeal membrane oxygenation with a VA setting is recommended. But again, this for difficult environments will probably not be an option at all, because resources are too few. This is how it could look like in the hospital if a patient is in hypothermia stage 1 or 2. So rewarming from outside, above and below, and very few collateral effects. So this is very good. So the algorithm for hypothermia rewarding of hypothermic patients has been published last year with the resuscitation guidelines of the European Resuscitation Council, and I would just likely briefly guide you through this. So there's the cold patient who is still conscious. So above here, there is the cold patient with vital signs. His consciousness is not impaired. And this patient should just be transported to the next hospital where he can be treated according to his illnesses and injuries. Otherwise, the patient in the middle branch of this algorithm could have impaired consciousness. So the core temperature is probably below 32 degrees. There may be signs of possible cardiac arrest in this patient, so low systolic blood pressure, cardiocirculatory instability, or core temperature below 32 in elderly and old and sick patients, or below 30 degrees in young and healthy patients. If one of these signs is present and you have the possibility in a difficult environment, this patient should go to an ECLS center, so with ECMO most likely. And if he arrests, he could be rewarmed with ECMO. But otherwise, if he does not arrest, he should be rewarmed, as we have seen before, minimally invasive with warm infusions and externally actively with warm mattresses and forced warm air. Finally, this is what I've said before. Finally, there's the cold patient who may arrest because he had one of these vitals with one of these signs, or basically he is already found in cardiac arrest. If there's no contraindication against resuscitation, then you have resources in these difficult environments. You should transport this patient to a center with ECLS rewarming capabilities, so ECMO better than cardiopulmonary bypass. Then you should check for the HOPE score, which is basically a 6-parameter score, which gives you the probability of surviving hypothermic cardiac arrest after ECLS rewarming. And if the score is above 10, then the patient should be rewarmed with ECMO, and otherwise it is recommended to consider terminating CPR at this stage. So what is the HOPE score? It has been published a few years ago. It has also been externally validated. You can basically look on this website. You just insert the age, the gender, then how hypothermia developed. So it may be with asphyxia, so for instance with avalanches, or if the patient has submerged, as we have heard before, in the water, or it was without asphyxia because he was just lying somewhere and then became cold and arrested. CPR duration time, serum potassium, and the core temperature, the first measured, and then a score will come out, and above 10, CPR and rewarming is recommended. If you do not have ECLS rewarming at hand and you have this hypothermic arrested patient, you may consider non-ECLS rewarming. This could be under continuous chest compressions, that could be manual or mechanical, peritoneal lavage, warm infusions, forced warm air, and warm mattresses. So whatever you have, but again, in a difficult situation with little resources, this may be very difficult. We have heard already about the rescue death. So the patient may be awake first, but then arrest along the way. Is this of any outcome relevance? Yes, it is, because with the rescue collapse happening on your side, you would of course start CPR if the resources allow. But if you see here, hypothermia 3 patients with or without circulatory arrest, the mortality doubled for those patients who were in cardiac arrest. And of course, very importantly, also with few resources, the length of stay of this patient was longer if they regained return of spontaneous circulation. So rescue collapse should be definitely avoided. In contrast, so I'm just coming to the end, in contrast to normothermic patients, hypothermic patients who go into cardiac arrest because of hypothermia, they have different criteria for ECLS rewarming. So normally an unwitnessed cardiac arrest patient with asystole does not qualify for ECLS rewarming, or ECLS treatment, but with hypothermia, this is no contraindication. I will not show you the data here, I just gave you some examples further down. And there is some more situations where ECLS rewarming should happen if resources allow. Finally, I just want to raise your attention to the special issue of the iJERP journal, where basically we have covered a lot of topics around accidental hypothermia, also in the trauma patients. You may read more there. It's freely available. And in conclusion, hypothermia, if hypothermia is there, we should avoid the cold and the wet and the windy. This condition, the combination is really dangerous for fast cooling and several side effects, as we have seen. We should transport these patients into a warm environment, consider passive, or that means by his own means, or active rewarming. Glucose should be applied to those who are depleted, who are hungry. Also, fluids should be given to those who are thirsty, and fluids are certainly required in many other occasions. Therefore, vital signs will stabilize and coagulation will also improve, and rescue collapse should be avoided. And if a patient has arrested and we have the options, then a HOPE score and ECLS rewarming, if resources allow, should follow. So that's the end, and thank you very much for your attention, and happy to ask your or to reply to your questions. Thank you so much.
Thank you very much, Peter, and I am happy to see back on stage also Marco Maggiorini, our previous speaker, and let me welcome my friend and President-elect Elie Azoulay, who is joining us now. Hi, Elie. And,
hello, good evening, everyone.
And also Marlies Osterman, a consultant intensivist at St. Thomas's Hospital in London, and also the chair of the research committee of the European Society of Intensive Care Medicine, and Claudio Sandroni, who is a consultant intensivist at Gemelli Hospital in Rome and the chair of the Trauma and Emergency Medicine section. Elie, we have received a lot of questions from our friends from Ukraine. Do you want to pick one and start the panel discussion?
Yes, there is one question that is very striking and very relevant. Is whether you provide data on hypothermia, and you also mention what can be the expected results and the patient journey. The way we are monitoring hypothermia might differ across countries and according to what we have in a given situation. Do you think that the results you presented and the patient journey you reported might be the same according to the way we monitor hypothermia? Not everyone has the same captors, not everyone has the same needs to monitor temperature. So do you think that this kind of variability might influence the results of your hypothermia protocol and patients' outcomes?
So should I answer to this question? Okay.
Yes, please.
Okay, so in situations where resources are scarce and no thermometer which is able, as we have heard before, is able to measure hypothermia below 32 degrees, consider the revised hypothermia Swiss staging system. That means look on the consciousness level. If the patient has no traumatic brain injury, if he's not intoxicated, then the level of consciousness in a hypothermic patient is certainly related to hypothermia. And the more he is cold, because his consciousness is impaired, the higher is the risk of cardiac arrest, but even more so in traumatized patients, the risk of coagulopathy will increase. So if you do not have any thermometers, just go on the conscious level.
Thank you very much.
May I add a comment? You were mentioning maybe also a difference between different temperature measurement devices. This may be very relevant because if you use, for example, infrared ear thermometers, you may have different temperatures. That if you are looking to the temperature at rectal level, or that may differ from core temperature. So this site and the type where you how they are measuring temperature, it's relevant. And it's relevant by the fact also that if you attempt to defibrillate your patient while in ventricular fibrillation is unsuccessful below 28 degrees, and to have a chance to successfully defibrillate your patient, you have to rewarm it up to 28 degrees. So have a fiable assessment of the temperature. I think it's important.
Marlene, so Claudio, any other comments on this?
No, both Dr. Paal and Professor Maggiorini have said everything I know about this, so I can't add anything more. It's been very informative for me to listen to experts. Thank you.
Then I have another question which is related to the current situation. Is there any difference in the speed of rewarming of polytrauma and gunshot injury patients with or without severe brain injury?
So the only data we have for, as far as I know, for the rewarming rate comes from animal data and also now one study from human data, and they show that a slower rewarming rate in patients who had been in cardiac arrest and had been rewarmed before development of FROSC had a better outcome. So the animals and the patients had a better outcome if the rewarming was not, let's say, above 2 degrees Celsius per hour. That's probably because overshooting of the temperature in cardiac arrest patients is avoided. For traumatized patients, there is no data, but what we certainly know is that hypothermia leads to coagulopathy. So therefore, just from a pathophysiological point, it seems very important to increase the temperature, let's say, within 1 or 2 hours instead of 6 to 12 hours to normothermia, to avoid further bleeding, because that may sum up to a few hundred milliliters or even more within a short time, and that may harm the patient.
And Peter, if I can ask you to elaborate a bit, because we also have a very difficult question, but we know about the situation at the moment. If you have no enough equipment for active control warming, which other strategies could you think of, like bottles of fluids or warming some fluids? How practical could you actually do in a challenging situation like this?
Yeah. So one thing which we should avoid is warming the patient next to a fire, because this is certainly too much heat, which is not controllable. But similarly to cooling patients when they have arrested in normothermia, where we use also cold things, we may consider using warm bottles or bottles as you use during, let's say, like in the bed for rewarming, if they have a temperature which does not supersede 42 degrees, because that may cause burns on the skin. Warm water may be helpful, but it should not be too warm. Some also consider in difficult environments warming from one to the other, so from one body to the other, but that of course is the last resort. And something around 40-42 degrees should be helpful. It should not be fire.
If I add something to answer the previous question. Concerning traumatic brain injury and the rewarming rates. So hypothermia does not confer any additional benefit in traumatic brain injury. And as far as hypoxic brain injury and cardiac arrest, which is a rather common occurrence in hypothermia, we recently reviewed literature, and there is no clinical evidence that the rate of rewarming affects the outcome. So I will stick to the practice, and in clinical trials, the rewarming rate, if you can monitor the temperature closely, is 1/4 of a degree to 1/2 degree of Celsius per hour. And this is in the ESICM 2022 guidelines of targeted temperature management after cardiac arrest.
Elie?
No, there's a practical thing to better understand the outcomes, and I think that what can be expected from hypothermia varies a lot across different clinical situation, but also with the way hypothermia is delivered. And I've been very interested by the part on the rewarming and everything on which we need to be careful with, and the possibility to see organ dysfunction appear when patients are rewarmed. So my question is about sepsis, and this is also one of the points that was raised in the question raised by our colleagues from Ukraine. So is there a specific way to address the infectious risk? Do you recommend maybe different clinical scenario on which you need to implement antibiotics? Do you have prophylactic strategies that you recommend that are in your experience useful? Or do you think that we should behave exactly like for all other critically ill patients?
As I said in my talk, the risk of infection is increased in hypothermic patients. And I think particularly if you have patients with open fractures and situations that are at high risk of infection, probably careful use, a prophylactic use of antibiotic in the first hours or days after injury, it might be wise. Because if you add sepsis in such condition, this puts your patient in really bad shape.
Thank you.
Okay, we have another question, and it's related to coagulation. You both explained the issues about hypothermia and coagulation, but is the coagulation issue something related to hypothermia, and therefore you just treat the hypothermia and that will sort itself out, or in the context of trauma, and clearly also context of possible bleeding patients, do you have to have particular attention and do something else about coagulation during the rewarming?
That's a good question. Actually, we do not know for sure what could be given. Again, in a difficult situation and scarce in areas with scarce resources, probably coagulation factors are not at hand. But just be reminded that this coagulopathy has developed partly also because of hypothermia. So as soon as you resolve hypothermia to normothermia, you will have just a normal state if no blood loss has occurred. But if you add too many coagulation factors also, if they should be available, that may cause let's say a hypothrombotic coagulable state, and that may be dangerous. So ideally reverse the hypothermia, and everything else is not that clear.
And would you monitor coagulation during the rewarming particularly, or and is there any specific test? I mean, I'm not sure it's easy to get thromboelastography everywhere.
Yes, and actually one thing could be added. Tranexamic acid, as far as we know, is probably an option, which is good. Which is good in traumatized patients. You will not do any harm, and you rewarm the patient. If you have point of care thromboelastometry, then that's good. Otherwise, fibrinogen, as we know, is a very good parameter. It's also one of the first to let's say to diminish, and probably the fibrinogen level, if you can monitor it, that should be done. Yeah, and just keep it around 200 milligrams per deciliter or above. Yeah, according to the bleeding, of course.
I think also if you have poor means, I think there are a few parameters that you can measure. Fibrinogen is one of them. I think you should measure platelet number and try to keep it at least above 50,000 if it's possible, if you have enough transfusion possibilities, and just to monitor the INR that helps it to assess globally coagulation. I would be very careful to do these measurements before the patient is rewarmed, because as you said, Peter, the techniques are not calibrated to be measured, to be used in hypothermic or cool blood. Yeah. So you need to have 37 degrees.
Yes, and of course, blood gas analysis is of course something which should always go hand in hand with resuscitation efforts. It's calcium, for instance. Calcium is often also.
Calcium is one issue. Well, thank you very much. I would like to wrap up and conclude by thanking the speakers. By renewing our very, very close thoughts and dedicacy to our colleagues from Ukraine. You need to know that we speak about you all the time at ESICM. We are really, really thinking on you, and everything we could do, everything we can hear from you that can serve the cause you are defending and for which we admire you a lot will be our cause. And with my president, Maurizio Cecconi, and all ESICM, and all our speakers and people in the audience tonight, we are thanking you, and we look forward to the next steps for the Solidarity, ESICM Solidarity webinars. Thank you again.
Thank you very much to all of you.
Thank you. All the best.
Thank you and good luck.
Bye.
Bye-bye.
All the best. Take care.